Hi, my name is Jean-Claude Tardif. I'm a cardiologist at the Montreal Heart Institute, and I'm here at the American College of Cardiology scientific sessions where I presented the results of the SELECT-ACS trial at a late-breaking clinical trial session. SELECT-ACS evaluated the efficacy and safety of an anti-inflammatory agent called inclacumab, a human monoclonal antibody against P-selectin. This study, SELECT-ACS, included 544 patients presenting with a non-ST elevation myocardial infarction and being treated with percutaneous coronary intervention, or PCI. Inflammation is increasingly recognized as an important process in coronary artery disease. Similarly, myocardial damage after PCI has now been understood to be in part related to thrombosis and inflammation. P-selectin is involved in interactions between leukocytes and platelets, leukocytes in the endothelium, and platelets in the endothelium, and therefore has potentially a role to decrease thrombosis and inflammation in the vascular wall. Hence, we tested this drug, inclacumab, to reduce the effects of the P-selectin pathway in patients with coronary artery disease. Again, the 544 patients were presenting with a non-ST elevation MI, were scheduled to undergo PCI, and were then randomized to one of three treatment groups: placebo, inclacumab 5 milligrams per kilogram, or inclacumab 20 milligrams per kilogram that was administered as a single infusion 1 to 24 hours before angioplasty. Patients then had repeated measurements of cardiac damage biomarkers, both troponin I and CKMBs, at 8, 16, and 24 hours, and the patients were followed for safety up to 120 days after PCI. There were 322 patients that ultimately received the drug, got the angiogram and the PCI, and had troponin I measurements both before and after angioplasty. This was a population of mostly males, Caucasians, approximately 60 years of age. The results are as follows. There was a significant reduction in the change from baseline in troponin I at 24 hours, a 24% reduction in the inclacumab 20 milligram arm versus placebo. There were similar reductions at 16 hours in terms of troponin I in the inclacumab 20 milligram per kilogram arm. There was no effect of the lower dosage of 5 milligram per kilogram versus placebo. There were also significant reductions in the peak troponin I observed anytime after 24 hours, a 24% reduction in that endpoint, and there was also a 34% reduction in the area under the curve for troponin I up to 24 hours after PCI. Again, the lower dosage did not yield any benefit. In terms of CKMBs, the results were very similar, favoring inclacumab 20 milligrams per kilogram versus placebo. Of note, the incidence of CKMB elevations above 3 times the upper limit of normal was 18% in the placebo group and 8.9% in the inclacumab 20 milligram per kilogram arm. In terms of safety, the drug was well tolerated. Specifically, there was no safety signal in terms of infections or bleeding when these patients were exposed to inclacumab 5 or 20 milligrams per kilogram. So in summary, we think that the consistency of the findings, both in terms of troponin I changes and CKMB changes, really support the concept that inclacumab, a P-selectin antagonist, reduces myocardial damage after PCI in patients presenting with non-STEMI. Further studies now will be required to evaluate other types of patients, STEMI patients, unstable angina patients, as well as patients undergoing coronary artery bypass graft surgery. Thank you for your attention.